Hello, hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. Thank you so much for taking the time to join me here, as always, to learn and to grow. I truly appreciate all the support. As I've said, the podcast has been growing, and it's been thanks to all the support, all the listening, all the sharing, and the liking. So, as always, I'm going to ask a quick favor off the top, which is if you get some value out of this episode, please do share it with a friend, send a link to their text message, Instagram them, put it on LinkedIn, wherever you can. Let people know that I have this amazing guest on today, Dr. Cameron McCrodan, who's an optometrist. By the way, we're also going to hear my one-year-old in the background here from time to time. Cameron McCrodan, who is an optometrist based in Victoria, BC, a 2011 grad from Waterloo. He is also a TEDx speaker. He did a talk about 10 years ago, and we're going to touch on some of the same things he talked about in that TEDx talk. He is a self-proclaimed skeptic turned expert in vision therapy. And I love that approach because I think many of us are, skeptics and would love to hear from somebody who's become an expert. His clinic in Victoria is called Optimization, but he also practices in Brooklyn, New York. And I think that's a really interesting thing I'd love to touch on. Thank you so much for joining me here, Cam. I appreciate it, man.
Oh, thanks for having me. I'm excited to be here.
Yeah, absolutely. So why don't you give me a little bit of an intro, if you don't mind, for those out there who don't know you that well, because you have a really interesting background before you even got into optometry. Tell us a little bit about that.
Oh man, so I grew up wanting to be an engineer, and I always wanted to be an engineer since I was a kid. I liked inventing things. I liked problem solving, and I wanted to invent stuff that would help people and change the world in some way. And then as I was going through engineering school, it kind of started to feel like I was just going to end up living in northern Alberta, working behind a computer, and that was going to be about the extent of my engineering when I was done.
Yeah.
So pretty quickly, I decided I wanted to do something else. And my dad, to his credit, made me go interview a bunch of different professionals: lawyers, dentists, doctors, surgeons,
Nice.
optometrists. And optometrists seemed to be some of the happiest ones of the bunch. Good work-life balance. They weren't on call. All these other things. So I was like, oh, you know what? Like maybe I'll go to optometry school. So I did the courses to go to optometry school. And something funny that most people may not know is I actually never had an eye exam before optometry school. My first eye exam was at optometry school.
Wow.
Yeah. So I'd never even been to an actually had an eye exam myself and at an optometry clinic or anything. I just kind of went there for it. And then getting through and getting out of optometry school, and those who remember me from our classes, I had a couple of run-ins, I think, with some of the faculty for stuff when I didn't think things were necessarily being organized or taught in the way that really benefited the students the most. But
That's
getting
funny.
out of optometry
Sorry,
school.
Cam, I'm going to cut you off real quick there. Knowing you, just the little bit that I do know you, I can see that for sure. See that happening. That you would be like, this is not the best way to do this. Let me show you how to do this right.
You know what? I think that was a thing of mine since I was a young child, and probably one of the reasons that my dad pushed me into doing something where I'd be working for myself or whatever. He's like, if you end up in a government position, everyone's going to be in trouble. And probably similar to optometry school, similar to my elementary school, I was usually either a prof's favorite student or their least favorite student. It was generally completely polarizing depending on how they approach their job. So I got out of optometry school, and pretty soon I really didn't like practicing primary care optometry. It wasn't doing it for me. It wasn't checking the boxes of that sort of engineering part of me that wanted to be solving more complex problems and dealing with that. And so I was actually going to leave optometry. I was 6 months out, and I saw my sister graduate from dental school, and I was like, holy cow, if I'm not going to enjoy my job, I'm going to go back to dental school, and I'm going to make 6 times as much money hating my job, so that I can retire earlier. So I'll still hate it. I'll just make way more. And a friend actually introduced me to the area of the sort of vision therapy side of things. And for myself, being a very natural skeptic, of everything usually, I was like, but I went and did a course, arts and sciences with OEP. And there was something that clicked about one of the guys that was talking there. And I realized pretty quickly, I'm like, oh my goodness, this is actually just the engineering of our visual system. And pretty quickly on, I realized that the reason my sister had struggled in school growing up was actually due to a problem with how her eyes tracked and moved and worked together. So then it kind of became personal to a degree as well. started getting those things figured out. And it was basically within a year and a half of graduating optometry school, I opened my first kind of vision therapy clinic. And it sort of snowballed from there. I left
That's
primary
amazing.
care practice in like 2000, was it 2014? I think I retired from primary care.
Within
um,
3 years. Yeah, that's great.
yeah. So and that's kind of what's taken me all this way. And then
Have
now,
you
yep.
did you have a course called we had a course in NECO called visual perception. Does that sound like something that you had? It
Yeah,
was
we
essentially it was a very theoretical type of course in that, like, it basically was showing all these neural networks. Then it looked like something out of an engineering or an electrical engineering type of course, right? There's just lines going to other lines and boxes leading to other boxes.
yeah.
Now that you're talking about this that seems like a course I feel like you would have enjoyed.
Although you know what, to be honest, I didn't even enjoy the course that much because at the time that I was doing it, there was no practical application for it.
Right. Fair
So,
enough.
to me, like the sort of the engineering part of me has always been in the side of like, okay, well, how do we actually apply this, and how do we do things that way, and about the
Yeah.
process and applying stuff. So, yeah, no, I definitely remember that course, but I wasn't a fan of it at the time. I think if I went back to take it, I'd have a lot more interest in it now.
Yeah, I bet you would. Absolutely, I bet you would. Now, in fact, you'd probably be teaching the course. Um, so let's talk about the skeptic turned expert. I think this is really important. Okay, maybe you can help me along the way here clarify something. With vision therapy, there seems to be people who love it and people like there's it's like you said, kind of like your personality in school, you're polarizing.
Yep.
People love it, and the people who love it are like obsessed, and it's like the best thing in the world. And then there's people who are like, I don't understand it, I hate it, I don't want to touch it. Or they people who don't think it works, like they totally discount its validity entirely. Why is it so polarizing?
Oh man, there's a number of reasons for this. But I mean, from where I came from, I can remember literally telling a family, when I was working in primary care, I'm like, yeah, don't do the vision therapy. That's total snake oil, total BS. They'll just take your money and
Yeah.
you won't get anything out of it. Go do some pencil push-ups type of a thing. Um, I think one of the fundamental problems for all of this comes down to our model of vision to a large degree. And I think there's sort of two parts to it. I think one is how we're taught to think. And then I think two is the model of vision. And then I guess actually maybe there's a third because there's a little bit of political stuff in there too.
Hmm.
Um, Model of vision, when we talk about that, for most of us, when we think of vision, we're just thinking of like clarity, the ocular health. What does it take for somebody to see clearly, the refractive stuff, and then again, physical health of the eye. And it's like transmission back to the brain. And then boom, you just magically have vision. What we don't realize though is that our brain is actually, I mean, essentially what's coming in our eyes is a bunch of ones and zeros, and our brain is
Hmm.
actually decoding all of that to make sense of what we're seeing. And by sense, it's not even just knowing what you're seeing, but where is it. When you're reaching for your microphone, your brain's calculated how far away that microphone is from you, and then it's actually using the visual feedback as you move your hand to keep adjusting your motor movements for that. Or
Right.
if you go to position your eyes on something, if you go to converge on something or move them, your brain has used the visual information to essentially get the coordinates of where it wants to position your eyes. It's like if you are going to fire a rocket or throw a baseball, you want to know the coordinates of where you want it to go, and then you make the
Right.
action based off of that. And so I think part of the issue comes down to a misunderstanding of some of those things for sure. I think also a misunderstanding of vision therapy. The way that I was taught, vision therapy was about making the eye muscle stronger. Okay.
Hmm.
When a child goes from learning piano, like from not knowing how to play piano to playing piano, the difference isn't in the strength of the muscles of their fingers. It's that they've learned how to coordinate their fingers in the appropriate way to play the
Hmm.
piano, and they've learned how to read the music appropriately to get that input and turn it into an output. So that was a huge shift for me in understanding that effective vision therapy isn't about strengthening muscles. It's actually about repatterning how the brain's controlling the muscles and processing the incoming information. And that's what makes a difference. So that's another one of the reasons that we have kind of an issue with things. I think the third one of the other pieces too is also syntax. And what I mean by syntax is this: if you take a bunch of people and you go, and this is where a lot of the fighting about vision therapy comes, and you go, all right, vision therapy helps kids with reading problems. Okay, that's a problematic statement because all kids with reading problems do not all have vision problems that are part of their reading problem. So, that's like being like antibiotics help people who are sick. And it's like, well, no, only
Mm,
if they have a bacterial infection that's leading to the sickness. And so there's
right.
this huge issue within some of the studies, research, and publications of exactly this problem. It's the same thing post concussion. If you go look up some of the more recent reviews that are published about vision therapy and post concussion stuff, one of the big issues there is that, again, it's the same syntax problem. Vision therapy
Mm,
should never be used to treat post concussion, but it can be used effectively to treat saccadic issues that have come up as a result of concussion. But that doesn't mean
gotcha.
every post concussion case. And that's where a
Right.
lot of the arguing in academia actually happens. And it comes down to syntax and understanding of those things. So that's one big place where I see that alone kind of spins out into most of the argument about vision therapy. Now, another
Yeah.
issue too, I think sometimes is that vision therapy also has a tendency to, I think, sometimes attract slightly more eclectic personalities, or things that seem a little bit out there. So then you do get more people who are making claims that may not really be based in kind of logic and optics and understanding of how our neurology actually works. And I think that
Okay.
also gets it sort of some of a bad rap as well. So there's a couple of different pieces there.
Yeah. 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 There definitely are some of those more outliers that I think can affect the overall view of the specialty, which is unfortunate. But that's the case in a lot of industries and a lot of professions, right? You get the people who kind of go a little too far over to one side, and then and they tend to be the loudest voices often in those ones as well.
And
So,
there's often truth within some of what they're talking
right,
about.
yeah,
Like take Irlen syndrome stuff, for example. Like I'm sure you're familiar with Irlen syndrome.
yes,
It's like, do the
yeah,
colored filters help you feel better when you blah blah blah? Now the problem they have there is another syntax problem. If the colored filters help you, they've decided you have Irlen syndrome. I mean, that's essentially the equivalent of saying, okay, if your arm hurts and you take Tylenol and Tylenol helps you, you have Tylenol syndrome. And it's like, well, no, you have a hurt arm and the Tylenol, yes, it makes it feel better, but it doesn't mean that your fundamental problem is a lack of Tylenol.
right,
And so the same thing's
okay,
been shown with Irlen, where the fundamental issues are actually binocular dysfunction problems behind it. So the Irlen filters help, but it's a misnomer to then use that as a diagnosis.
right.
Um, and so
But
that's I think where the engineering part of me gets so into some of these things, because you can actually cut through most of the arguments when you actually understand what's going on and then the language behind it that's causing people to fight about it.
right. When you use logic, it's funny how sometimes you can actually get to the right answer. So let's talk about your own skepticism and then how you decided, VT was the right path for you.
Oh man. So yeah, so like I said before, I told multiple patients that VT was just, total snake oil and BS. And so it's also funny because when I have a parent in the office who I can tell is kind of thinking that, I'm like, look, man, I was the biggest skeptic of this in the beginning too. So like, I get it. Ask the hard questions. I think what wound up bringing me around though was um, a number of things. And I don't know, have you read much Scott Adams?
No, I have not.
Okay, so Scott Adams is the guy who did Dilbert. And
Oh, okay. In
he's
that
written
case,
a
yes.
couple. Yeah, yeah, so you've read lots of Dilbert, but he's written a couple of neat books. And in one of his books, one of the things he talks about is that our schooling often teaches us how to think. We're taught how to think about things. And so within optometry, and I don't know about your school, but a big one for ours was like, okay, you listen to the history, you do your tests, you make the diagnosis, and for treatment, you do what the manual says for treatment
Mm,
for that diagnosis. And
mhm,
and then there's new peer-reviewed studies that come out sometimes, and if those say to do something else, then you do something else for it. In engineering, how we're taught to think is you go, all right, what are the symptoms? What problem is somebody or something having? Let's investigate any system that could be responsible for those systems, and then obviously within our scope, but investigate the systems that could be responsible for it. Are any of those systems not working properly? And then do we have a way to help that system work better? And
mm,
then if so, what do we do? And like that's sort of more the engineering mindset of it. And so I think that's where my skepticism started to disappear with things, because I was always interested in the mechanisms of stuff. So have
Mm.
you heard people talk about like microprism before?
Yes, absolutely.
Okay. So the way that microprism was originally brought up to me was like as though it was like magic. Like it's like,
Yeah,
oh,
yeah.
like microprism, it's this magical thing. And so having the engineering optics background, you look at it and you go, okay, well, what is the prism actually doing? And thankfully, I had a great instructor at one point who talked about this a little bit. But what's the prism actually doing? It's actually shifting depth and spatial perception. So, we know that when you move your head, your inner ear sends signals to your visual system telling you how much your head is moving so that you can
Right.
compensate with the correct eye movements. So essentially, the two systems are linked together and integrating properly. And if your inner ear's saying things are moving and your vision's telling you something different, we're in trouble. That's what seasickness is.
Right.
Okay, you've got a mismatch. Now, when you change someone's prescription, positive, negative, magnification, minification, or using prism, you can change the ratio at which they see the world move when their head moves.
Hmm.
So we know that by changing prism or magnification or minification, you can change how quickly somebody sees the world move when they move their head. And that can be the difference. That's called VOR gain. That can be the difference between does somebody feel stable or not. You can also actually use the lenses to change somebody's perception of depth and space. So, you can use lenses to make somebody think things are further away from them, closer to them,
Hmm.
further to one axis or another. And so all of a sudden, thinking about these things that are sort of talked about as like magical in VT, you're all of a sudden going, okay, well, no, there's actual like optics here. And we know the process of how the brain uses the vision. Like that makes linear logical sense.
Right. And so some of those things that you're talking about, minifying, magnifying, changing the spatial perception, we do those inadvertently,
Oh,
uh,
yeah.
accidentally, unintentionally, when we're just prescribing our regular, whatever lenses.
So
It could be single vision, could be progressives or whatever.
absolutely. So like every lens itself has these effects as soon as we start playing with somebody's refraction. I mean, how many patients have you had before where they love how they feel in their contacts and they hate how they feel in their glasses?
Oh yeah, every day.
That's often it, because think about the two different worlds the person's transitioning between.
Right.
They're going from basically a very natural VOR gain in the contact lens to all of a sudden, they're at like a -4 or -5. Their world actually looks and feels very different,
Yep.
and their brain
Yep.
has to all of a sudden reintegrate all these ratios differently.
Absolutely makes sense. And I actually use that explanation. I love that. Thanks. I appreciate your what's the right, verifying some of the things that I'm saying to patients. I've been just sort of saying, I'm sure I learned it in school or something, but like I'm sort of saying intuitively that, yeah, when you wear your glasses, it's minifying or magnifying. Hence, it maybe doesn't feel as comfortable as what you see through your contact lenses. So I appreciate that. So now I'll feel more comfortable when I make those statements. Um, what part of VT would you say is maybe not as effective currently? Like what in our current perspective of what understanding what VT does, average person's perspective of what VT does, what's not effective? What maybe should
Hmm.
we not be doing when we're doing vision
Um,
therapy? Is there something that can be disposed of?
yeah, I think it comes down to, I think the one thing we should never be doing is treating symptoms without an understanding of why or a knowledge of the mechanism. So, and I think that's one of the big problems that people assume is it's like, oh, a kid has trouble reading. We're going to throw vision therapy at them and see if that helps. And it's like, well, no, if a kid has trouble reading, let's make sure that all their saccades are accurate and work properly. Let's make sure that they've got stable binocular vision the whole time and their accommodative system can do what it needs to do and all these other things. And if all those things work great, then, from the VT world, there's not really anything to offer them. If and there's more to test than just that, but just as an example. And I think that's what we've got to get rid of within it is the idea, both sometimes within people within the profession and people outside of the profession, that the vision therapy is being used to treat this other condition rather than the visual things that are part of it. A great example of that is
Yep.
autism spectrum disorder. Many kids with ASD have binocular vision problems that respond really well to treatment. But you're not treating the ASD, you're treating the concurrent binocular issues that are there. And
Right.
that's where a lot of stuff gets messed up. Same with dyslexia. You can have cases of dyslexia where there's no vision problems at all. And a good friend of mine was like that. I was so excited. I was like, dude, there's a good chance, eye tracking is part of your issue, and we may not solve the whole thing, but maybe we can make it better. Tested it.
Right.
Absolutely not. Had nothing to offer.
Mm.
Whereas, again, a lot of people may have dyslexia and may have significant tracking and binocular issues that mean that the parts of the brain involved in dyslexia aren't even getting the information properly in the first place. So, they have both things. And that again comes back to the syntax of what kind of gets vision therapy misunderstood or in trouble that way.
Mm.
So I think
I want to come back to the student part. Pardon me.
I was going to say, I think that's what we have to stop doing. We have to be, very clear about what it is we're treating and the role that it plays.
I think that's an easy mistake to make, and gets made a lot in general, though, is painting everything with one brush, or like too broad of a stroke, right? Just kind of saying, oh, vision therapy helps with a bunch of these things, but not really defining in a much more specific way. And again, it's not just vision therapy. If we just keep it within optometry, there's so many things. We could talk about that within dry eye. This happens, dry eye, you probably have dry eyes. We could probably fix it. Now, you might have dry eyes, but it may not be related to the other thing the other issue that you're dealing with. But sometimes it could be, and we tend not to like separate these things enough, I feel like. But using it for very specific scenarios, it can be super powerful. We just have to define those a lot better for people, so we're not making claims that are a little too, audacious or whatever. Talking about students and learning and reading, your TEDx talk was primarily on that topic, but there's something else that you do, which I teased right off the top, which is you go all the way to New York and you do some work there. And I was so interested to learn about this. I'd love if you could just share what you're doing out there and the type of impact it's having.
Yeah. Kind of coincidentally, a good friend of mine wound up getting me involved with the Orthodox Jewish community in New York. And so we wind up helping those kids with reading and learning stuff, because they spend like 8 to 10 to 12 hours a day reading. It's a huge part of their life, huge part of their community, huge important part of their religion. And so the reading is so, so important. And that experience taught me so much about, all sorts of lens prescribing stuff, eye movement, efficiency things, like so much in that area. And so it was a pretty neat thing. I haven't been there now basically since the beginning of COVID. My visa ran out, so I'm in the process of getting that all set back up again. But it was a pretty amazing experience. And, especially again, in a culture where reading is so important. A lot of the time here, how we kind of treat it is like, oh, you can't read. Well, you will just use text to speech or just whatever, or find something else you like to do in life.
Right. But there it's so valuable. So tell me about the next thing I want to talk about is kind of the impact that you feel that you've been having, with your patients. But in that specific scenario, then we'll come back to BC. But in that specific scenario, what kind of things are you seeing? What are families saying to you? What kind of impact is that having on people?
The difference in kids' trajectories, their ability to sit and focus, their ability to learn, their frustration, it was massive. And for families, if they had if they had a child who was really struggling in school, the family was really worried, because that kid would get frustrated. They'd often kind of get ostracized a little bit within the community. They'd have a much harder time integrating. So for the family, it was a massive concern. So if you could help normalize their reading and improve their abilities in those areas, it meant everything to them.
And so normalizing is one thing, of course, that's going to help relieve a lot of the
Or
stress
enhance.
Pardon me?
I said, or enhance. Hey,
Well, that's the
if
next
you
thing I
can
want
take
to
it
ask
from
is
normal, even
enhancing.
better. Yeah.
Yes. So that's one thing before we go into the thing I actually wanted to talk about, which was the impact that you have on patients' lives. Before we go to that, like one of the frustrations I just have in general about Western medicine is that we don't talk about optimizing. We just talk about preventing, not even preventing, just fixing disease states.
Yeah.
But like, what about somebody who comes in who is functioning pretty well? but wants to function better, wants to optimize, wants to enhance. We don't do enough of that in general. Like when I go to talk to an MD about like, all right, well, looks like all my blood tests are normal, but like I want to get a little bit better at this or have a little bit higher levels of this. Like, what can I do? They look at me like, why? What are you talking about? But we do the same thing with vision. Oh, you're 20/20, good to go. But what kinds of things could we potentially be looking for that we can do for somebody who has normal vision function to enhance it?
Well, and I mean, here's the whole thing when we talk about normal, and what you just mentioned with blood tests is it's like, well, normal according to who?
Mm,
It's, oh, you're in your blood tests are normal. Well, does that mean that you're functioning well, or does that just mean that you're in this area where they don't consider you diseased enough to be a problem? And
exactly. Yes.
so that kind of ties back again to that engineer's mindset of kind of going, based on the needs of your life, are there areas that we can make things work better? So when we talk performance enhancement, like I've got a race car driver where, he sees pretty much 20/20 at distance. But what we found out was he had a very small binocular kind of like instability at distance, slightly vertical, slightly horizontal. And using the right lenses, we could keep his vision way more stable as he was like ripping around the track at 200 miles an hour. And for him, that meant better braking times, better everything, better performance. Or around a reading and focusing side of it, I'm actually a great example of that. I got through school pretty well, but I could only focus for like 3 pages at a time, 4 pages at a time. I was the first one done every exam in optometry school. I had like a limited window, and I didn't even realize it at the time. But from the second I started writing the exam, I just wanted to be done. I just wanted out of there. I don't think I even ever looked over an exam twice. I never double checked my work
Mhm.
until I did my boards fellowship. But it was by that time I'd actually treated my own reading stuff so that if I wore my appropriate glasses when I sit and read, I can focus for much longer. And I actually double checked a test for the first time. So when we talk performance enhancement, I think one of the big things we have to consider is that our human visual system isn't made for our modern world. Our human visual system did not evolve for sustained periods of up close work. Our visual system is really meant to be scanning out there, working more at a distance with intermittent times
Mhm.
of up close. And I mean, quite frankly, our evolution hasn't really selected for visual systems that work well past the age of 30 or 35 through our history either. If
Right.
people really care, but we won't get into how evolution works, but people weren't, the selective breeding didn't happen for, people over those ages with clear vision. That wasn't really a consideration. So our visual system, if we work off of the understanding that our visual system is not really made for a lot of the modern day demands, then we kind of go, okay, how do we help improve how it works under these different scenarios? And that can include extended periods of computer time, extended periods of reading, or other things that people are doing that, again, we haven't really evolved to do. How do we help them do it better? Sometimes it's from a therapy side, sometimes it's simply how we prescribe lenses for people. um, yeah, and then the tie into that though is what you mentioned earlier. Be careful of the marketing for things as well. A lot of the company reps hate coming to my office unless they really know what they're talking about. Because, well, seriously, they'll tell you, they're like, "Hey, we've got a lens that focuses at all these different distances, and there's zero compromise." And I'm like, unless you've reinvented the laws of optics and the laws of physics, that's not actually possible. You can't have these different distances at the same time on the retina without some level of compromise. So let's be frank about what the compromise is. And then at least people can go into it in an educated manner.
I'd love to be a fly on the wall in a lot of these interactions that you have with people. But honestly, the other thing I want to do is learn from you. We're going to talk about that a little bit more towards the end here, because we will have the opportunity to learn from Dr. Cameron McCrodan in the coming months. But before we get to that, the impact, I want to go back to that because I think this is really powerful. You have a very specialized clinic. You're getting referred a lot of patients from different types of practitioners. People are traveling to come and see you. This is something you've developed and built over the years. In those kinds of cases, when I talk to doctors who have those, whether it's in dry eye, whether it's in VT or some other cases, they really can help people who are in a really tough spot. So I'd love to hear some of if you can share a couple of stories where, you're proud of things that you've done, where you've helped a couple of people,
Oh
who were
man.
challenged and weren't able to, get the relief.
The Well, one of the things that comes to mind almost right away, because I was in tears in the office last week. Um, I've had 3 people in the last 3 months tell me they had plans to commit suicide because of their headaches and
Wow.
dizziness. Each one of them had been facing it for, sort of 2 plus years. Nobody had any real answers. They'd been through all sorts of stuff. And in each one of those cases, actually, a huge part of their symptoms was actually a pretty severe kind of binocular visual dysfunction, and sometimes some like visual vestibular stuff happening and whatever else. And even just the right glasses and lenses made such a difference. And last week, I had a woman sitting in the exam room, and I put the trial frame on her with the stuff, and all of a sudden she said like her world stopped moving, and she
Hmm.
could look at me without feeling the strain and all this other stuff. And it wasn't like a prescription like you just sort of normally find. It's often the kind of thing that in school we were taught to dismiss. It'd be like, sort of like whatever. And I mean, she's broke into tears, and then so did I. So it's hard not to when somebody's feeling that and you're highly empathic. It hits you pretty hard. And so I've had a number of those. I think one of my other favorite ones, and it's funny with kids. I mean, you've got young kids, but kids often, I mean, if you remember when you were a child, you don't really remember much past a few days before, and if you like, your time window of consideration is so small. So
Yeah.
kids don't often reference as much stuff themselves. But when you watch their confidence grow because all of a sudden they can read the same way their peers can, or they're doing well, or they see themselves learning, and they see themselves like that. And you just watch how differently they start interacting with the world and how they carry themselves and all these things. You know, that's probably one of the other really, really meaningful ones. Um,
Yeah.
and then I guess another one too in the last month or two as well was it was like an 80-year-old patient of mine where even just how her progressive lenses were changed to consider the depth and spatial perception stuff, and even a tiny bit of vision therapy based around depth and spatial stuff, and all of a sudden she could do stairs again. She wasn't falling in her house all the time. Her
Mm.
level of independence had improved massively. Her she's no longer bumping her car into most things. She doesn't have to drive by feel. Um, so
That's
yeah,
insane.
there's a number of those things that sort of
Yeah.
hit you.
That's incredible, man.
I joke with my patients. I'm like, you know what? If I won the lottery, I would still do my job. I would just not have to worry about a mortgage. Like,
Yeah, yeah. That's special on its own to find somebody who loves what they do. And like I ask people this often, what would you do, if you didn't have to worry about getting paid? And if you choose to do the same thing that you're doing now, that's pretty amazing that you get to do that day in, day out, man. That's really special. But to help people in those positions, that's profound. Somebody who's considering, you're saying they're actually planning
yeah.
their
And
suicide, like,
that's
not even
that's the
a thought.
difference. That's the
Yep.
difference between thoughts and the if you've talked to enough mental health providers, it's the plan
Yeah.
that really indicates how serious things are.
Yeah. That's crazy. But, great job, and it's, it's amazing that you're doing that and able to help even one person in that position. That's profound, but you've had a few of them in the last few months alone. Amazing. Helping children, again, going back to that part, that is for me. So fortunately, unfortunately, I haven't had the experience of patients who are considering suicide, but on the children's side of things, there have been numerous kids throughout the years who I've seen progress and improve, and that's really, really rewarding to see as well. One of the things that you and I talked about recently was kids who come in, 3, 4 years old, and they're practically nonverbal, or they're really behind in their speech development, and you see they need glasses. In some cases, a very simple prescription. In others, maybe there's a bit more going on. But when you prescribe that, and 6 months later, a year later, all of a sudden they're like almost caught up to where they should be, and it really was the simple act of bringing them in for the eye exam that kickstarted that whole process, and parents can see it too. And one of the things I say to a lot of patients is, and to parents in serious situations like that, is if the visual system's not functioning right, it's just draining so much energy from the rest of the brain that other parts of the brain can't work the way they're supposed to. And you've done something that actually shows this. I'd love to hear a little bit about that. What you've done, kind of test it out to kind of prove that theory.
Yeah. Oh, so the EEG. Yeah, I mean, I think you're totally right. I use the same explanation with people a lot of the time. Vision's 70% of the sensory information coming into your brain, and over half of your brain's involved in using it. So if it's not working efficiently, it's really hard to do other things. It's one of the reasons a lot of people have really poor reading retention is if their
Mm,
brain's having to put so many cognitive resources into the simple eye movements themselves. There's
mm,
less of a channel, there's less attention, there's less cognitive resources available for actually paying attention to and understanding and retaining what we're reading. So, one of the things that we've looked at, which kind of came up in an interesting way a number of years back, is there's a little test called pattern glare. So it's like high contrast black and white lines, and we'd often use that with people to see if they're visually sensitive. If you want to tell if someone's headaches or migraines are due to their vision, show them pattern glare, the black and white lines. And if that
mm.
makes somebody feel like it's going to give them a headache or a migraine, then what do we know? Vision's one of their triggers. That's like kind of like if you have allergic reactions and we go, you know what, Herbie, we want to see if you're allergic to peanuts. So we give you a peanut and you swell up. And then we're like, all right, well, doesn't mean it's the only thing you're allergic to, but we definitely know it's one.
Yeah.
And so the same with the pattern glare, black and white
I don't
lines.
think that test would fly these days, though. You'd have to be a little careful about that.
The
The
peanut
peanut
stuff.
test.
But instead, they just do the little like cuts in the arm
Yeah,
with
yeah,
little things so it doesn't blow it all up. But
yeah.
what was neat with the pattern glare is if you change somebody's glasses or lenses to provide the most stable binocular vision, you would actually see that they would have a subjective change to their response to the pattern glare. They'd go all of a sudden, oh my goodness, those black and white lines don't bother me as much anymore. Cool. Like, or I
Interesting.
can look at them, or it's not as aggressive, or, oh, it still bugs me, but it's not as bad. And then what
Right.
we found is that if you actually hook them up to an EEG and you watch what their brain is doing, you will see an objective change on the EEG that correlates to the subjective change.
Amazing.
So, you're actually watching changes in how the brain's processing the visual information based on the stability of the binocular system. And
Very cool.
again, correlated to their subjective experience, which is nice because when you're involved in a lot of medical legal stuff and whatever, the objective experience is kind of thrown out to some degree, which is hard.
Yeah, that's pretty cool that you've done that, and nice to know that there is that relationship there. And it, again, bringing credibility to the theory that I'm sharing with my patients. So now I can go back and can speak to my patients with a little more
Yeah, see, you
confidence
were
about
already on
that.
top of it. You just needed me to come in and be like, "Yeah,
I
you're
just
right."
well, I appreciate it. Yep. Well, yes, it's nice to have a little have an expert come and verify some of these things that I was sort of doing on a bit of intuition there. So I'm glad I was on the right track. So I want to learn more from you, Cam. And you are going to provide an opportunity for someone like me to learn more from you. And I'd love for you to share a bit more about that, what's coming down the pike and what to look out for. So if someone like me who does very little or no binocular vision VT type stuff wants to start to get into it, we can kind of start leaning that way and optimize our practice.
Yeah, so I mean, a lot of this kind of comes from I think who I am naturally, and then my journey through this. One of the things I realized very quickly is that, and a lot of people will, if you have interest in getting into the vision therapy side of things, even if it's just like more effectively prescribing lenses and glasses for certain stuff, or whether it's like full blown you want to do therapy, it's hard. There's like multiple different educational bodies. They all kind of are
Mhm.
siloed and kind of do things a little differently. And in my education, especially in the beginning, I realized pretty quickly that one of the downsides of some of these silos was that people would be very just kind of into their way of doing things and not always recognizing the benefits of some of the other VT stuff that was out there, or even aware of their own holes within some of the theory and stuff. So my goal over the years has been to kind of piece things together from all the places that I could and then systemize things. I'm a systems guy for stuff. A lot of people's version of VT, and it's funny when I trained my associate, I think his idea of what VT would be like and what it was like in the exam room is very different than like how we actually run it at the office. You know,
Mm,
my new patient visits are, it's like 20 minutes of pre-testing and then 40 minutes with me. Whereas most of us were used to like at our schools, like a 3 hour long appointment with all this stuff and angle
yeah,
A and angle S and like all these things. And there's a lot of that stuff that a lot of the time doesn't actually matter that much. Like, is it actually
right.
going to change what you're going to do and your outcome? So my goal has been, to how do we boil these things down into such a sense that we can empower people to make a lot of change for patients without necessarily having to run a full-blown VT practice or without having to go do all of these things. But how do we bring, even 80% of that knowledge to the primary care provider, the primary care optometrist who may want to get more interest in that area. So coming up, we've got some courses that'll be coming at sort of like different levels and different layers of that to be able to allow people to integrate a lot of that knowledge into their exam. How great would it be if you're doing your exam with somebody and pretty quickly, how to manipulate a progressive lens prescription so that they don't reject it, so it actually enhances their depth perception as opposed to not, and it doesn't have to ruin the flow of your exam. There's all of these little things that can just be done. And some of them are so simple. This is a non-optical one, but one other thing you might not know about me, I don't know if I shared it when we talked, but I mean, I spent a few months living in Whistler, actually taking courses in language, and the study of like neurolinguistic programming stuff. But so at the beginning of every exam, I ask people two questions, and this is a great take home for the listeners of the podcast. I ask them two questions. I say, one, before we begin today's exam, which takes the pressure off because we're not beginning, but before we begin today's exam, is it okay, as we go through history, is it okay if I interrupt you sometimes just so I can dig deeper in certain places? And no patient is going to say no to that. So they go, yes. And then what do you have? You now have permission to interrupt somebody where you need to, and they are happy about it. So as they're going through their history, you can kind of interrupt to dig deeper in spots, and it's not awkward. Everybody's happy.
Yeah.
You can keep things on track and you can get what you need, because there's nothing worse than sitting there having somebody spill to be like everything, and they're giving you what they think is helpful info, but it's not, and you're afraid to interrupt.
Right.
And then the second question that I ask all my patients is, what would you like out of today's appointment? What would make today good for you? So it's not just what the chief complaint is, because, so much of the time you'll have people sitting there and they'll say, my wife just told me to come, blah, 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 blah. And whatever they tell you, you now have the criteria for making today good for them. They've literally told you what needs to happen for them to be happy with their experience. And that changed a lot for me, because otherwise I was sitting there assuming or projecting what I thought they wanted out of it.
Right.
And those two things completely changed it. So
that's amazing. I think, definitely, asking that seems like almost, for me, maybe almost a bit of an awkward, both of them would be slightly awkward questions to ask, but I guess once you get comfortable asking them, then it's fine.
The only awkward part is how you feel about asking it. And it kind of felt like that in the beginning. But when you just approach it like they're the natural questions to ask, I've had so many other healthcare providers as patients who've been like, can I steal those? Like, I'm going to use those. Or I've had so many patients be like, wow, nobody ever asks that of me. They just ask me what my symptoms are, and then the doctor just kind of does their thing and tells me what I need to do without often taking into account what does that person actually care about and want. Because there's a big difference between somebody who just wants a diagnosis and somebody who wants treatment. There's a big difference between somebody who just wants to feel better about having a condition, or maybe they're super worried about it and they just need some peace of mind.
That's so funny you just said that, because right before that I was just thinking, you're right, because sometimes people just want to know that they're okay, that they don't have glaucoma. My mom had glaucoma and I want to make sure I don't have it. That's what they want to get out of the exam. And we start saying all these other things, and then at the end they'll be like, oh yeah, so what about the glaucoma? And because they don't have it, you don't think to say it, but that was the thing that they really wanted to make sure they didn't have. That was the thing they wanted.
You nailed it. And then we'd have a tendency to sort of brush it off. We'd be like, well, yeah, of course you don't have glaucoma. Whereas if you've asked that in the beginning, hey, you can, instead of spending 5 minutes talking about X, Y, or Z, you can actually spend 5 minutes showing them their OCT and making them feel confident and comfortable on how you're going to monitor that each year for them. And you've just spoken into their listening about what they want to know.
Yeah, absolutely. That's great. So asking what it is the patient would like to get out of the exam today. And
the key question there is also what would make it good for you? So what would you like out of today's appointment? What would make today good for you?
I see. So it's a two-part question, I guess you
Yeah,
could say.
it's sort of a two-parter, but
And then
it's
the other question is, as we go through the exam, can I interrupt you? Would it be okay if I interrupt you to go a little deeper, to learn a little bit more?
yeah, yeah.
So
Like kind of as we go through your history, is it okay if I interrupt you sometimes just to dig a little deeper?
dig a little deeper. Got it.
And
Well,
that's
I
the
know what I'm
language
going to
that
be
works
asking
for
people
me.
tomorrow.
I mean, everybody will end up with their own version of it, but essentially, again,
Yeah.
you've gotten their permission for it, and
Yeah.
and and they're happy about it. You've totally reframed interrupting someone.
Love it. Absolutely. Yeah. Definitely put a positive spin on that, because you're interrupting to learn more. You're interrupting to provide a better outcome, not just because you're rude and you don't want them to keep talking.
Exactly.
Which
Otherwise, that's
might
what
be
people
part of
assume. People assume you're trying to
yeah,
rush them
of course.
instead of being like, you know what? No, that's an interesting point. Like, I want to dig deeper here.
Yeah. Love it. So Cam, there's two questions I ask everybody at the end of each podcast episode, but before we get into that, here's a chance, if you can share some information of how can people get a hold of you, learn more about you, where would you like people to go?
Cool. So opto-mization.com is our website. I think if I realized I was going to have to repeat that out loud so many times, I would have branded differently. But seriously, if you Google Cameron McCrodan, there's not many of us out there, so it pops
Yeah.
up pretty darn quick. I
Okay.
don't know if we have a link on the site yet, but I think once we have it for registration for some of the course material we're going to be putting out there for people, because again, my mission in life is actually to change how we deal with vision in general, and that involves using a lot of the stuff that we've learned, even within the context of primary care optometry, which will make it more meaningful
Yeah.
and better for primary care ODs and better for all the patients too. And how do we distill down these simple things that actually work that can be done in that? But so I'll send out a thing for your listeners once we have some registration stuff for it. But for
Cool.
right now, people can learn more just sort of through the website. You can always, send us an email if you want, because we will keep a list of emails for registration for that stuff too. Because
Great.
I'll tell you,
I'll put
it's been
a
an absolute game changer.
Amazing. I'll put it in the notes here on the podcast, or if you're watching on YouTube, in the caption underneath, link to the website and maybe Cam's email address or whatever email address you want people to reach out to. And then what I'd like to do is I'm gonna take your course or courses, and then we'll have you back on after I've done it, and you can test me, see how much I've learned.
Well, you know what I think the fun part will be is that I think it's not even just a question. It's not meant to be one of those things where it's just learning in terms of testing for stuff like that. But I look at it like going, are there ways that we can enhance the process of how we, even on the simple act of prescribing, are there ways that we can improve how we actually prescribe the lenses, and then even how the lenses are dispensed to better the outcome for the ODs and for the patients for that too. So that's
Yeah.
that's really going to be the core concept of it. Can we distill down a lot of the meaningful things that I've learned in the last 20,000 hours of doing this and implement those things into primary care practice in a way that makes it more meaningful,
Mhm.
more, a better return for the docs and for the, and better outcomes for the patients too.
Yeah. I love that. One of the concerns these days is um the commoditization of what we do as optometrists, and the concern that we'll just become refractionists for some large organization, sort of, and that is the case if you choose a certain path in the profession. That is going to be your career, unfortunately, if that's a choice that you make. But if the rest of us want to thrive and we want our profession to thrive in the long term, it's doing stuff like this is that's going to help us do it, right? It's not spinning the wheels and selling a pair of glasses. It's providing a service that's above and beyond. It's helping solve problems that other places can't solve. It's implementing these types of specialties into our practice. So I highly encourage anybody out there who's even a little bit interested in doing a bit of BV, keep an eye out for this. I'm definitely going to do it myself, and I'm going to report back. So I look forward to that. Now, there's two questions, as I said, that I ask everybody at the end of the podcast. Number one is, if we could hop in a time machine and go back to a point in your life where you were struggling, having a hard time. If you're comfortable, you're welcome to share what that moment was. But more importantly, what is the advice you would give to young Cameron at that time?
Oh man, I I'd say there's sort of three. It comes back to one of my favorite sayings. one, the two most important days in your life being one, the day you're born, and two, the day you figure out why. And
Mm,
I'd say the third one is sort of when you realize how your unique combination of experiences, challenges, triumphs, and character traits puts you in a position to do things that are a unique strength of yours. And I think this is really important for a lot of optometry too, because both through school and through our colleges and everything, we're kind of taught, well, an optometrist is an optometrist is an optometrist, and everything's kind of the same. And
mm,
I really hated that at times when I was first out practicing. And you kind of brought it up, like in terms of the refraction piece. But what I'd go back to say to myself, and what I found so powerful within that is, okay, none of us are actually just optometrists, whether it's outside hobbies and things we enjoy and love, or parts about our personalities, or parts about what got us to optometry in the first place, or other experiences we've had. Once we realize how we can pull from and integrate those other parts of ourselves that bring really a unique part of us to that, and how we can utilize that in the context of our practice, I think then work becomes way more fulfilling. You know, I
mm.
it's funny that you mentioned refraction, and just a tangent for like, I'll keep this under a minute, but I used to hate refractions because it was like, okay, I felt like here, like I'm basically doing an auto refractor thing. Anybody can do this for you, blah, blah, blah. When when I started being able to approach refractions in the sense of going, how do we optimally help your depth perception work? How do we give you better reading? How do we reduce your headaches and migraines at the computer? And you're thinking about that during the refraction. All of a sudden, the refraction actually became this incredibly powerful agent for change for a person. And it became way more enjoyable and way more fun. And
Mhm.
not only that, but then I never even had a glasses dispensary in my office because I hated the commoditization of glasses and I hated the image of that, until I realized that so many places, both expensive and inexpensive, don't pay attention to some of the things around making glasses that make the difference between how amazing they work or how they don't. And then so all of a sudden, having a dispensary was actually one of the most ethical things that I could do for my patients. Which, I mean, by the way, we have a satisfaction guarantee on all our glasses. If they don't love them, they can return them for a refund. There's all sorts of things that we do that make it really like it is literally the most ethical thing we can do for them. But it also means that the prescriptions we give people are actually what they end up looking through. OCs aren't messed up, prism centers and pals aren't doing weird things, or yoked prism. But
Mm,
anyways, I think that is the piece in the nutshell, is coming back to what are the things that uniquely make you you, the traits that you have, the experiences that you have, and then how do you integrate that kind of into your mission and your skill set and what you can do in life, because then you really feel like you have something, as opposed to just kind of being another, dial spinner or whatever.
yeah. Yep. Yep. Absolutely. So the last question that I ask is, everything you've accomplished to this point, how much of it would you say is due to luck and how much is hard work?
Huh. Uh, I I don't think you can actually fully tease those things apart. So I'm a very firm believer in, basically. I mean, you're familiar with our reticular activating formation. So,
Yes.
and now, all of you listening to this who've thought of buying a new car, and you've probably heard this before, the minute you've thought about buying that car, how many of those cars do you see everywhere when you drive around?
Right.
Okay, do all of a sudden more people have those cars? Absolutely not. But your brain can only process so much info. But once you've set an intention and once you're aware of it, you're more aware of what's there. So, what I really say is that a big part of luck, a lot of the time, is also being able to spot the opportunity amidst the sea of other things. And, so there's a huge component to being able to be present, to spot the opportunity, but then also to be able to take risk and go with that and work hard through that. Because you'll see a lot of people who just work hard, but they can't do those parts. And you'll see people who are
Mm,
lucky, but they actually never really seize the things that are there. So I think I've had a wonderful combination of the two things over the years.
yeah, that's wonderful. I love
And
it.
a lot of
No,
things
it's
are
definitely
luck
a
that
tricky
don't,
answer.
a lot of things are
What's
luck
that?
that don't look like, I was going to say, a lot of things are luck that don't look like luck at first.
That's true
You know,
too. That's
the
true.
old
And
the
a lot
old
of
farmer's
people,
parable,
what's
you
that?
know? So the old farmer's parable is where the farmer has a wild horse, or his farmer loses his horse, and all his neighbors are like, "That's so bad. That's such bad luck. You lost your horse." And the farmer's like, "Well, good or bad, don't really know." And the horse returns the next day, and it brings with it a wild horse. So it's got a second horse, and his neighbors are like, "That's amazing. That's such good luck. Now you have two horses." And the farmer's like, "Well, good or bad, I don't know." Because then his son breaks his leg trying to tame the wild horse,
Oh,
and the story goes on. Like, I'm not going to go through the whole thing, but it goes on like that.
yeah,
And for the most part, our judgments of what's good or what's bad, or what's lucky or what's unlucky, are sometimes only in the context of what we can see in that immediate time, as opposed to how does it play into the bigger picture, which a lot of the
yeah,
time depends on what do we do with it when it's there. Are we
yeah,
a victim of circumstances, or do we figure out, given this, how do I proceed?
yeah. I love that. And actually, now that when you started reciting that, I realized I had heard that before. But absolutely, that's a good story to keep in mind. The question, of course, is intended to create a bit of a dialogue because it's really hard to. But some people do. They'll say 90% hard work done.
Yeah.
All right, great. 100% hard work. And maybe that's what it is. But you're like, sometimes we just don't realize that there's luck involved. We just don't perceive it as luck at the time. If we look back, maybe hindsight, we start to see how lucky we were. So I appreciate that. Thank you, Cam. Appreciate the answer. Thanks for sharing everything that you have. Definitely want to have you back on because we need to start talk a little bit more. As I told you before, I don't do a lot of clinical type conversations, and this one wasn't at all because this was a lot more about like how we need to think about VT and how we can change the profession or our practices. But I think we need to do a bit more of a clinical conversation where you can talk about some how to's, how to fix this problem, how to solve this issue. So we'll have you back for that, and then I want to do that course, and we'll see how that goes as well for my practice.
And it'd
But
be fun
any
at some
final
point.
words you want to say before we
Well, I
go
was
on?
just going to say it'd be fun at some point to get into some of the more contentious topics too, because those are the things that I love digging through on, like, the logic side of it as well.
Yeah.
So yeah, more than happy
I
to do
love that.
that.
I want to get angry emails from people in VT about, the fact that we talked about things that they find sacred.
If you're doing it right, if you get angry emails from people on both sides of
Yes,
the coin, like, then you've
that's
got
true.
it. Yeah.
That's right.
Um,
That's a
I
good
guess
point. That's a good point.
last words, what I'd say is, for anybody out there who's listening, if you're in the Victoria, Vancouver Island area, always feel free to give us a buzz and, come check out the office. More than happy to kind of, show people around. Or I'd encourage them, in their local area, if they're co-managing with VTODs, get to know them. Go check out how they approach things, because it will be different depending on the person, and you'll find somebody where you kind of mesh well with, and the practice works well, and it can be a really symbiotic relationship.
Yeah, that's actually a great idea. And actually, that's another one of the points I like to make when it comes to strengthening our profession is working with each other, right? OD to OD referrals and connections like that is what's going to help strengthen our profession versus either ignoring the problem. So let me just go on a bit of a tangent. When we ignore a problem, somebody else is going to come and fill the gap, so to speak, there. And that's not always going to be an entity that we want to be there to fill that gap, right? So we need to, with our relationships amongst one another, fill those gaps. But it helps provide a better perception to the patient too. My primary care OD knows what he's doing because he or she sent me to a specialist in the area who knows what they're doing, and I got a good experience. And I go back to my primary care OD, and I'm happy with that whole relationship, versus something not happening, to that effect. And that's going to help us build our entire profession in the long term. So I like that little point that you've made as well. So thanks again, Cam. Appreciate your time, and I look forward to having you back on again. And thank you, everybody who's watching and listening to the 2020 podcast, Canada's #1 optometry podcast. I apologize for the babies in the background, but this is life. Thank you for listening, and I look forward to seeing you guys in the next episode.
Thank you.